happens now is that early transplant patients don't do too bad at all.
Don't do
if
bad.
they acquire, no, they do very well because they are on high doses of steroids.
Immunosuppression,
We are live now, sir. We are less than a minute away from our scheduled time. So, Rela sir, the way this works is that we'll just give a brief introduction about this event, and then you would start your presentation. The audience would be asking the questions, and they will be posting it in a text format on the YouTube chat window. And then at the end of your presentation, we'll pass it on them to you for your answers. And then we'll have a short.
Read it out. Somebody can ask questions anyway.
Yeah, I'll read it out.
Four of you on the screen. No one else is on the screen.
Yeah. So you can start your screen here now.
Are they coming in the Zoom as well? People are coming into the Zoom as well?
No, there are just the 3 or 4 of us on Zoom. Everybody is watching you on YouTube.
Oh, I see. Okay.
Yeah, it's a live broadcast on YouTube, and people are already there. I can see almost 50 people who are already logged on to YouTube.
Okay.
And the number is increasing every minute. So, sir, would you start sharing your screen first, and then I'll start with the introduction.
No, you can introduce me, and then I will start screening. Don't worry.
Yeah.
And then I'll say something and then start.
Okay.
Is that okay?
Yeah. Okay. So welcome everyone. We welcome Professor Rela and Dr. Sanjay Rao and Kirti, who is joined with us and has helped us coordinate for this talk with Dr. Rela. I welcome all the audience on this platform of IAPS webinar. And Professor Rela, thank you very much for accepting this talk and speaking to the fraternity of Indian Association of Pediatric Surgeons. And on behalf of the President IAPS, I would like to thank you for accepting this talk. Sanjay Rao sir, thank you so much for joining in, and it was way above our pay grade to moderate this talk, and I hope you will help us out in that. So Professor Rela does not need much of introduction, but I'll make an attempt towards that. He is the director of Rela Institute and professor of hepatobiliary surgery and liver transplant at King College London. He has almost more than 4,500 liver transplants to his credit. And his name is there in the Guinness Book of World Record for doing a transplant in a 5-day-old girl, which I saw that there is a lot of news about that girl, sir, who is almost 22 years of age and is doing really well. So that speaks a lot about your work and your art of liver transplant and that science of your field, sir. Thank you once again. I will hand it over to Dr. Sanjay Rao, sir, to say a few words, and then Professor Rela will start his presentation.
Yeah, Ravi, thank you very much. As I said, I think Professor Rela comes with a large experience of liver work, even in children. And I think probably one of the few who has the whole spectrum, resections and transplants and everything else, and surgical diseases, including biliary atresia. Besides the surgical part of it, I think he is also a very serious academician and has, can speak to you on any aspect related to this at length with great authority. And he has a lot of material to show for it as well. So without much ado, I think I'll, hand the mic over to or hand the screen over to Dr. Rela, and please request him to make his presentation.
Thank you, Sanjay and Dr. Ravi and Dr. Kirti Kumar. It was Dr. Kirti Kumar who contacted me, and I want to thank the Association of Pediatric Surgeons of India for this opportunity. I have already, I think, spoken to you. I think I've even operated in one of your meetings, I think, on liver resection. Today I'd like to hold on. Let me open the screen. We just tried it out and it was there already. I think it needs to be open first. Yeah, the talk is going to be on pediatric liver resections, but not pediatric liver tumors. I'm sorry. It's going to be on pediatric liver resections. And really, I started, I'm an adult surgeon. You're all pediatric surgeons. And I started my career in King's College Hospital and got really interested in pediatric transplantation And I worked within a large pediatric hepatology unit, and it was a referral center for both, you may know Professor Ted Howard, who had an interest in biliary atresia, and so it was a referral center for pediatric liver surgery as well. And at that time, my boss was Casey Tan, who was a pediatric surgeon who had a interest in pediatric liver surgery, really. I moved to India, and now I worked in Global Hospital for 10 years, and I've moved to an institution now, which is really named after me as Rela Institute. And we have been very, very busy, both with respect to pediatric liver transplantation, pediatric liver surgery, and adult liver transplantation. I think we now do almost 250. The COVID time has been a little dull, but we still continue to do around 10 liver transplants and a number of probably pediatric liver transplant numbers are slightly higher now than adult liver transplant. I have seen the advantage of how liver transplantation has helped HPB surgery. There are many people who are brought up as HPB surgeons, and there are many who start off as liver transplant surgeon and move into HPB surgery. The European system has actually combined liver transplantation with liver surgery, whereas the American system, the surgeons are all multi-organ transplant surgeons, and HPB surgery has been a completely different specialty. I think there are many ways where the two systems have worked together and given us really courage in understanding liver anatomy and pushing the boundaries in liver surgery. And really, I think it is extremely important to understand liver anatomy, really, to understand liver surgery. And I think liver transplantation has been helped. I just want to tell you the story as to how I got interested in pediatric liver resections and pediatric transplantation. And this publication is an example. And you will find that I published this X5O liver resection in a 15-year-old girl who was referred to me by a very famous pediatric surgeon. You will recognize that I share this publication with Louis Spitz. Louis Spitz was the head of pediatric surgery in Great Ormond Street at that time. And he tried to resect this tumor that you see on the right-hand side, where this was actually not a liver tumor. This was an extra-adrenal pheochromocytoma that was really pressing into the liver. That diagnosis was made after resection. And this was really at the confluence of the three hepatic veins. The right vein, middle vein, and the left vein were actually joining, you can see in the picture, joining into, before the three veins join into the inferior vena cava. This was really the tumor. And he felt that this is a completely unresectable tumor and referred it to King's for liver transplantation. He referred it to me for liver transplantation. I felt that this was possible to resect it if we actually took the liver out. So this is where I'm saying the advantages of combining liver transplantation with liver resection. So I felt that it was possible, but I was a very young surgeon. This publication's already, when this was published, 2006. So that's almost 17, 18 years ago. I was a young surgeon. I had no guts to say to Professor Louis Spitz that I can resect it when he couldn't resect it. So I accepted for transplantation. We put the patient on the waiting list, but on the day when the child was offered the organ, I took the child to theater and removed the liver and actually excised the tumor on the bench. So these are the advantages of really the split liver transplantation, and excised it on the bench and then reimplanted the liver back into the child. So this what gave me really some sort of an authority within London to take on pediatric liver tumors and pediatric liver transplantation. Really, that pushed me, and people recognized me as somebody who was able to do liver resection and manage. And after that, really, I was very much involved with the CEOPL study group, and Professor Ott in Belgium. He's a well-known pediatric liver surgeon in Belgium, was my mentor, and I've had many discussions with him. And was very involved in hepatoblastoma and the management of hepatoblastoma. And that's how I came into. And there are many, I've been involved in renal tumors invading the IVC, and really hepatocellular carcinoma invading the IVC, protruding into the right atrium. So transplant experience has really given me an opportunity to push boundaries in liver surgery. So what I want to convey a positive message. I don't want today to say to people who are listening that pediatric liver resection is very, very difficult. It needs to be done in higher centers. In fact, the opposite is true, that pediatric liver resections are probably much easier than adult liver resections. The liver itself, I think whatever it is, the consistency of the liver itself is much firmer than adult livers. There is no fatty infiltration. There is no abnormality in these livers. They are perfectly healthy liver. Even chemotherapy actually doesn't damage liver that much in the pediatric patients, and they are very resectable. But if you get into trouble and if you actually make mistakes in them, then they get into trouble, the children. I would expect that pediatric liver resections should have almost, I think, close to 100% survival. There should be no perioperative mortality. And I can say that holds good for us. I don't remember having in the last 25, 30 years, having a perioperative mortality in a pediatric liver resection. So only if you get things wrong, if you get your outflow wrong, if you get large segments of the liver ischemic that you leave behind, that patients can get into trouble. So in order to really understand pediatric liver resection, you need to be extremely good with the understanding of liver anatomy. I think if you understand liver anatomy, you can really go ahead and do. And there is nothing to be afraid of. The point is about understanding anatomy, dissecting out vessels and dealing with these vessels, rather than really doing a bulk tissue, putting big clamps in the hilum, putting big clamps close to the veins and tying them and suturing them. I think if you are meticulous with the work you do, I think the outcome for pediatric liver resections is going to be extremely good. And this is generally with the mortality of liver resections. I think it's improved tremendously. And as I say, the pediatric liver resection should carry very little mortality. I'll start off with really the anatomy of the liver. The earlier classification by Rex, just to say the right lobe and left lobe to the right of the falciform ligament, is redundant. That was very early on in the 1800s. In 1954, really, the Quino is the one who described the liver anatomy into a segmental liver anatomy. And he described it into really a right lobe and a left lobe through the plane of the middle hepatic vein. So this is the problem. One of the biggest problem with the liver anatomy and the difficulty with the liver resection is it's not two separate anatomical entity. Even though we call it two separate anatomical entity in terms of the inflow, the outflow between the right lobe and the left lobe is shared by the middle hepatic vein. And so it's not like a right kidney and left kidney where you can easily separate it off and they are independent of each other. If you want to take the right lobe, you may interfere with the outflow of the left lobe, or if you want to take the left lobe, you may interfere with the outflow of the right lobe. So that is the situation that makes it difficult. The left lobe, this is like this picture that you see is not really real. This is not how you see a liver. The right lobe is divided into the right anterior and right posterior. It's segment 5 and 6 are right anterior, and they are located between the middle vein and the right vein. In fact, the right vein, which is located between the right anterior and posterior, mainly drains only the right posterior. In fact, the right anterior sector drains into the middle vein, which is peculiar. There are very few branches going between the right vein and the right anterior sector. So the 5 and 8 drain into the middle vein. The 6 and 7 drain into the right vein, and that separates the right anterior and posterior. Now, the right anterior and posterior, if you open an abdomen and look at the liver, you actually don't see the right posterior sector. The 6 and 7 are not visible to you. But when you do a liver resection, you can mobilize the right lobe completely and put a large swab behind. Then this liver looks like this. This liver is only possible to look like this if you completely mobilize the liver and then open it like a book. And the left side is a horizontal. The left lobe is a horizontal lobe, and therefore it's divided into the left lateral and the left medial sector. So it's a horizontal plane into medial and lateral, whereas the right lobe is anterior and posterior. And the principal plane that you see, the middle hepatic plane, is not a vertical plane. It's not a plane between anterior to the posterior plane. In fact, it's an oblique and more horizontal plane than a vertical plane. But you can make it into a vertical plane by mobilizing the right lobe again and lifting the right posterior sector into what you see like a picture. So anatomically, what you see is not how you see the liver, but once you mobilize the right lobe, this is how you see the liver. And the transection plane can be made somewhat vertical, so it is easy for you to do the operation. So this is what I mentioned when I said you lift the right lobe of the liver, and now you can see the posterior sector. The 5 and 8 are the anterior. The middle hepatic vein is drawn in the middle there, and the 7 and 8 are the posterior sector, which you can make horizontal. Now, the liver is attached, as you know, by only 2 parts. One is the falciform ligament that goes up, and then posteriorly is the bare area of the liver, which is where the liver is attached. This plane, the mobilization of this plane is really not very difficult. It's a very flimsy layer that you see mostly in children. It always is a flimsy layer. It's only when patients get cirrhosis, the livers become hard and contracted, and there are collaterals which develop between the anterior abdominal wall of the liver, this plane would be extremely dense and it would be extremely bloody to do. Otherwise, mobilization of the right lobe is actually very easy in children. And up to the point you see the vena cava gets mobilized. Occasionally, when you mobilize the right lobe of the liver, the right adrenal gland, which is on the upper pole of the kidney that you see here, will be very adherent to the liver. And it's not uncommon sometimes that the adrenal gland is a very fatty gland. It's actually splits in the middle very easily. So you can actually split the adrenal in a horizontal plane into 2, and the posterior part can sit in the back, and the anterior part can be stuck to the liver. It's not uncommon to see that, but if you can secure hemostasis on either surfaces, it does not matter. So in order to avoid that, you really have to work very close to the capsule of the liver to leave the adrenal gland behind. But it's not a problem in most of the patient. And in this particular patient, you can see there is also an inferior hepatic vein, inferior right hepatic vein, and you can have many caudate vessels here. Another point I want to talk about with respect to the adrenal gland, when you have very large tumors of the adrenal gland, it's very commonly confused with liver tumor. This mistake is made by many radiologists as well, that they say it's a liver tumor, and you go in and then prepared for a liver resection, and then you lift the liver, and there is a tumor under the undersurface of the liver, and it's not easy. And here is an example. There is a large tumor which looks like a right lobe liver tumor. Nobody would even think that this is not a HCC in the right lobe of the liver, but this is actually an adrenal tumor, and the diagnosis can be made preoperatively. And how would you make that diagnosis preoperatively? There is only this relationship of the cava to the liver. The cava is posterior to the liver, and a liver tumor will never push the cava anteriorly. That's anatomical. It's impossible for a right lobe liver tumor to push the cava anteriorly, whereas an adrenal tumor can push the cava anteriorly and to the left. And here is what you see. The cava, portal vein, and this is the tumor. This cannot be an anatomy in a liver tumor. This you should remember. So if you look at the cava and see that the cava is anterior and to the left of the tumor, it can never be a liver tumor. This is an adrenal tumor. So it's important to understand the relationship of structures around the liver. And foramen of Winslow, you know, it's very useful that you open the gastrohepatic ligament and then you get control. If you're early in your career, you want to have control, you can pass a sling. I don't like the idea that this picture shows that there is a soft clamp across the porta hepatis. That's not necessary. And you can do liver resections by Pringle maneuver. Usually you put a sling around it, like the cardiac surgeons do, and then tighten it, and that is the way you can do. And people do liver resections with Pringle for almost 20 minutes at a time, or they can do it for 1 hour. The only thing I want to remind you when you do Pringle is if you render the gallbladder ischemic during the Pringle procedure, and post-operatively, I would advise, if you do prolonged Pringle, to do a cholecystectomy. If you're not going to, if it's a wedge resection, or if you're doing a left hepatectomy, you've done a very prolonged Pringle because you've taken a long time to do the operation, because you can get acalculous cholecystitis, an ischemic cholecystitis post-operatively, which will confuse the picture, and the patient will get sick, and you'll never know why the patient's got sick. So if you're going to do a prolonged Pringle, the liver will sustain an ischemic insult much better than gallbladder will do, and therefore it's better to do a cholecystectomy when you do Pringle procedure for a long period of time. Now, coming to the Hilar plate, and the earlier description of liver anatomy talks a lot about the Hilar plate system. It's a peritoneal reflection, really, which runs along the blood vessels, the gastrohepatic ligament that surrounds around the foramen of Winslow. The structures in the porta hepatis is actually carried by the blood vessels into the liver, and this plate, or this peritoneal reflection, covers the blood vessels in a very tight capsule. So you can actually go around the structures all together. You can go around the artery, the portal vein, and the bile duct system all together, and then tie. And people say that if you go around the right pedicle, around the Hilar plate, you could put a weight of almost 10 kilograms and it won't come through. I don't think I've tried that. So it's quite a tough system, and people in the early days used to actually ligate all the structures, and even now there are many older surgeons and some bold surgeons who will go around the right anterior or right posterior, or even the entire right. I think with the advent of now laparoscopic liver resections and things like that, people are coming to an idea that this may be very easy to do. If you can go around the whole of the left Hilar plate, if you go around all of this, you can probably put a staple across and divide it across with a staple, and then you could do the resection laparoscopically very comfortably. So that the older anatomy system, but is coming popular now with the advent of really robotic surgery and laparoscopic surgery. But I think for all practical purposes, if you want to learn to do liver resection, I would advise you to actually dissect out the blood vessels, see them for yourself, and then ligate them and divide them individually, which would be the best way to really learn. And this is what I was talking about. This is a right-sided system Hilar plate, where there is a sling around it, and that's where the surgeons, you can pull on it and tug on it. Nothing will give way because it's extremely strong to hold all three of the blood vessels together. Now, the liver anatomy itself, I think this is a picture that I've taken during excision of the bile duct, but this was for a type 1 cholangiocarcinoma. So all the structures are there. The most anterior structure is, let me just take this image. The most anterior structure is the bile duct, and the hepatic artery runs immediately behind it, and the portal vein is the most posterior structure. So we have removed the most anterior structure, and you see the openings of the left hepatic and the right hepatic duct here. The right artery runs behind the bile duct. So the bifurcation of the artery is not behind the bile duct. The bifurcation of the artery is below and to the left of the bile duct. It's important to remember here that the left artery is completely away in the left border of the porta hepatis. So it's very difficult to damage the left artery in any Hilar dissection, whereas the right artery is very vulnerable if you're doing biliary surgery or your choledochal cysts, or even cholecystectomies. When you do, it's the right artery which is vulnerable, because it is lying immediately posterior to the bile duct. The portal vein is far behind. The bifurcation of the portal vein is at a much higher level than the bifurcation of the artery. So the bifurcations are also at a different plane. The bifurcation of the bile duct is the highermost in the hilum. Below that is a bifurcation of the the portal vein, and the bifurcation of the artery is at a much, much lower level. So when I always talk about bile duct tumors, when you get the hilar tumors, even the inflammatory pseudotube tumors that you want to deal with, they are extremely difficult because they are really wedged deep inside at the bifurcation of the portal vein. So they're not as superficial as you might think it is. So you have to be very careful in understanding this anatomy. Now, the posterior sector, many people would prefer to do the posterior sectoral excision if you want to do a local excision by really going around the posterior inflow altogether. And that is probably easier than any other part. Finally, I want to say that there is a similarity between the divisions of the bile duct and the divisions of the portal vein, whereas the arterial division may not match that of the bile duct. So there is a difference. So if you've got an early bifurcation of the portal vein, if you've got two portal veins going to the right side coming from the main portal vein, you're likely to have two bile ducts as well. So that is important to understand. When you've got two portal veins and two bile ducts, it may be difficult for liver transplantation because you have multiple reconstructions, but for liver resections, it's more convenient when you're doing segmental liver resections when you've got separate portal veins and separate bile ducts. So for resection anatomy, it's not a bad thing. Now, the bile duct blood supply is also something which is very important to understand, particularly for extended hepatectomies, because the most common complication that you see, I think it's not common to see bile duct strictures except when you do extended right hepatectomies. When you do extended right hepatectomies, you're isolating the left hepatic artery and pushing it away. The blood supply coming from below may be interfered with. And you commonly get strictures of the left hepatic duct because the left hepatic duct are very long ducts, and they are much more vulnerable to ischemic insults in extended right hepatectomies. Otherwise, if you really respect the blood flow to the bile duct, you shouldn't get any problem with strictures in the bile duct in liver resection. Intraoperative cholangiograms are there for you to really check at the end of the operation if you've gone too close to the bile duct. Now, we have talked about the anatomy of the right lobe and the left lobe. You want to get a demarcation if you want to know exactly. I think it's always safer to do anatomical resections than to do wedge resections or non-anatomical resections, because when you do, the tumors don't respect really anatomical planes. They may be sitting between the anterior and posterior sector, and if you actually go in and wedge a large tumor out, thinking it's easier, actually the blood loss will be much higher when you do large wedge resections, and then you unnecessarily open up bile ducts. And when you open up bile ducts, you get bile leaks in the postoperative period. So unless they are very peripheral tumors that you can easily wedge out, if there are large tumors sitting in the center, even if they are sitting in the surface of the liver, it's advisable to do anatomical liver resections rather than do big wedge resection, thinking I'm going to leave behind a lot of liver. I'm not going to do any hilar resection. So to get a demarcation, actually, you need to actually interfere with both the arterial blood supply and the portal venous blood supply. You can actually temporarily block them, put bulldogs or spoon clamps, and then see and mark the line of demarcation, and then you can do a formal liver resection easily, and that is also possible. So that is the principal plane. The principal plane is at the base of the gallbladder fossa, where the segment 4 is to the left. So this is a left lobe demarcation, and that was a right lobe demarcation. I always talk about the Rex rhesus. We can, in the questions, if you want, we can talk about Rex shunt and access to the left portal vein. The access to the left portal vein is actually pretty much the left-sided anatomy is very long. The left portal vein is very long. You can see here, the right portal vein divides into anterior and posterior pretty much immediately, whereas the left runs under the segment 4 for a long distance and then turns anteriorly and then only divides into the first branch on the left is a segment 2 branch, and then the segment 3 branch, and then on the right side it gives off the segment 4 branch, like a branching. And all of these vessels can be actually isolated, visualized. You can see the artery on the left border of the rex recess here, and the portal vein here. And this is very anatomically suited for really mobilization. And we have described an operation for cholangiocarcinoma using the rex recess approach as well. That may be something interesting for you to know. So it's important to understand that the left portal vein is long and it's very accessible for a long distance. Now, caudate is also important to understand. Many people ignore the anatomy of the caudate. The caudate receives its blood supply and the portal venous supply right at the bifurcation, both from the right artery and the portal vein. It can get blood supply both from the right side and the left side. So it's in between the two. And its venous drainage is actually directly into the IVC. So when you do liver resections, the difficult part maybe for beginners would be really to separate the caudate lobe from the IVC in its entirety. But in a right-sided liver resection, it is enough that you really ligate the caudate veins up to the middle of the vena cava, or maybe right 2/3 of the vena cava, and don't have to go to the left side of the caudate. And the caudate actually is not something that you see as the Spigelian lobe. The caudate's got 3 parts. The paracaval portion is a part that runs all along the length. In fact, it runs from the level of the porta hepatis up to the insertion of the hepatic veins. So caudate is not so small as you think, and the caudate processes to the right side. And the Spigelian lobe that you see under, when you lift up the left lateral segment, is what you see under the liver, which is visible on the surface. In fact, you can't see the paracaval portion and the caudate process, which are within the posterior aspect of the liver, which is within the parenchyma of the liver. And I think I've always said understanding the anatomy of the caudate lobe reduces the biliary complications after liver resection and liver transplantation, because we published this a long time ago. It's got very complex biliary anatomy. There are multiple bile ducts draining from the caudate lobe into the caudate lobe into the junction of the bile duct, the left and right bile duct. So this is one of the pictures that was a hand-drawn picture, really, published in American Journal of Transplantation. So we always talk about cut surface bile leak. You would have seen after liver resection, you get a bile leak, and people always say this is a cut surface bile leak and it will settle down. But not all cut surface bile leak will settle down, because when you do a left lateral segment, if you see here in the first picture, the segment 4 duct actually curves back into the right side. And when you transect a left lateral segment out, you're exposing the segment 4 duct and it's opening up. And if the anatomy, if the blood supply of the segment 4 is still intact, it'll continue to produce bile and it'll leak on the cut surface. And that will be a leak on the cut surface from segment 4, which is still viable, and that will never stop until you go back and suture it. And there are many instances where you transect the caudate duct in a very similar manner. When you transect the caudate duct will also leak from the main duct, and that causes bile leak. So one has to be really very meticulous, look at the cut surface of the liver to identify bile ducts. Mostly the bile ducts the small bile leaks that come from the caudate bile duct. Most of the caudate bile duct may actually seal on its own. You don't need to worry, but it unnecessarily prolongs keeping the drain in, and can also really cause septic complication in these patients. If the remnant is very small, if they get septic complications, that may lead to mortality, really. So it's very important that you avoid bile leaks post-resection by understanding. And really, if you get caudate lobe tumors, I mean, they are much more difficult to deal with. And here is an example of a tumor which is just involving the caudate lobe. And now I put this up for you to understand the size and how a caudate lobe really wraps around the IVC. It's not what you see on the left side alone. In fact, this is the paracaval portion, this is the caudate process, and this is a Spigelian lobe, and this tumor extends anteroposteriorly throughout the length. And to remove this tumor is very difficult, really. And this is a tumor where I really split the liver into two. This did not require any margin because this was a neuroendocrine tumor, fortunately, and the outcome was pretty good for this patient. Once you split the liver into two, you see the tumor right in the middle encircling the cava. So what we did was to actually excise the cava along with the tumor. And you see the final result of the operation, where the left lobe is left behind, the right lobe is removed with the caudate tumor, and the cava is replaced by a PTFE graft. And the blood supply of the left lobe looks pretty good after that. So caudate tumors are very, very difficult to really manage, and probably not something you should attempt at liver resection. That probably needs to be managed at specialist centers. Now, the imaging for liver surgery is not really huge, actually. I think you could mostly manage with MRIs or good CT scan, because good CT scan will give you a lot of information in terms of liver vasculature, the volumetry, the functional status of the liver. The biliary anatomy probably requires an MRCP in major liver resections, but in straightforward liver resections, you probably don't need to do liver imaging. The other thing to remember is the remnant liver volume. In adults, people expect to have a remnant liver volume of 30%. You can do 70% hepatectomy comfortably. I think you can, in the living donor setting, we do up to 70% hepatectomy comfortably, but in the tumor setting, perhaps you could do up to 75% hepatectomy. I would say in the pediatric setting, you could do up to 80% hepatectomy comfortably, as long as you don't damage the remnant left lateral segment. You can do up to 80% hepatectomy. But having said that, don't venture into a 80% hepatectomy. In the tumor side, volumetry are much more difficult to manage, because when you have a large tumor in the right lobe, how can you calculate remnant volume? Because you have to exclude the volume of the tumor itself, because the tumor doesn't work like a normal liver. But in a HCC, it becomes much more complicated, because in HCC, it may be contributing to some function as well. So it becomes very complicated to measure remnant volume when you're operating on large tumors, because the remnant will look very small if you include the tumor within the volume of the liver that you're going to remove. If it's a large right lobe tumor, the right lobe is going to be so large that the remnant will be less than 10–15%. But you can't calculate like that. I think when the tumors are small, remnant volume may be better calculated, but in large tumor, it becomes redundant. I don't want to go into the complicated anatomy, intrahepatic anatomy, because these are not so relevant for resection. They are more relevant today for transplantation. But it is important to remember that there is always an overlap in anatomy. Here you've got a the right sectoral artery, right posterior sectoral artery draining into the left-sided, artery draining into the left side. So you do a liver resection, a proper left hepatectomy, you can make the anterior sector ischemic in terms of the arterial blood supply. But I think the liver is very forgiving. Even in this sort of situation, you make the anterior sector ischemic. If the posterior sector is undisturbed, you may get away without any problem with just an atrophy. And these are anatomical variations where imaging may not even tell you what is going on. See, here is a situation where you've got the right artery dividing to the left of the bile duct and straddling the bile duct, dividing into anterior and a posterior branch. This is very useful when you're doing a sectoral bile duct excision, anterior sector resection or a posterior sector resection, because a portal vein can also divide in a very similar manner into an anterior and posterior. So sometimes anatomical variations may be more suited than be a hindrance. Portal vein anatomy is beautifully delineated both in the MRI venograms as well as in the CT scans. I mean, I rely hugely on CT scans for really planning the operations for liver resections. I think that is more than enough. And nowadays these are all CT images. I think most most centers who do good quality CT scans can give you these anatomical details. I mean, you should expect that from them, and they should give you sort of reconstructive images. Otherwise, you should not accept it, actually. They're all done routinely with CT scans. You can have large inferior right hepatic veins. We saw a picture of that. And you need to be very aware of this when you're mobilizing the liver. They can get easily torn because you think that the vein is not below and somebody is lifting the liver without recognizing them. I think identifying them and ligating them early in right hepatectomy is necessary in order to there have been disasters during laparoscopic hepatectomies where people have actually damaged this early in the course. There has been a mortality really in a right hepatectomy, laparoscopically done, where this vein was damaged and they did not have the time to open and sort out the situation. Similarly, it's important to remember the left and the middle vein have a common orifice. I'm going to show a video of that where you will recognize this anatomy. And that is why when you do extended right hepatectomies, because pediatric liver tumors can be very large sometimes, in those situations, if you do an 80% hepatectomy or a 75% hepatectomy where you're removing the right lobe and the segment 4, if you actually narrow the outlet of the left lateral segment, you get into trouble. The patient will not survive. If you get a 20-25% remnant and the outflows narrowed down, then that is an important problem. Sometimes also you'll find that the left lateral segment 3, will also drain into the middle hepatic vein. And if you see this anatomy, you have to be extremely careful. The type C anatomy that you see. In this instant, it's very difficult to do an extended right hepatectomy. Maybe it's not possible to do an extended right hepatectomy. You may have to really do some vascular reconstruction in this sort of setting if you want to do major liver surgery. So this is, again, not something for you to venture into. And there are many biliary anatomical variations as well. I wouldn't go into the details of those. And intraoperative cholangiograms, if you have any doubt, at the end of the procedure also you can do cholangiograms to make sure there is no bile leaks. You can actually flush with saline to see if there is no bile leaks during the operation. One of the common anatomies that you need to remember is really a right posterior duct draining into the left duct. I don't have a picture of that. I thought I had the right posterior duct will often drain into the left duct. And when you do a left hepatectomy, if you damage the right posterior duct draining into the left duct, you will have a bile leak that you will never, and that requires a loop to be put into the site of bile leak to solve the problem, because the entire right posterior sector will be open on the cut surface and will permanently leak. You will get if you treat it conservatively, that child will have a biliary fistula lifelong until you go and sort out. And there have been many instances I've seen that children have had biliary fistulas for 5 years, 10 years because of that mistake. I don't know if any of you have seen those things. And finally, they'll end up with secondary biliary cirrhosis and come to transplantation. I think it's very important to understand the anatomy in these situations. Now, just we already talked about the remnant liver volume. The rules for children is different from rules for adults, but I would say to anybody that if you have a remnant of 30%, you can comfortably do the operation. Don't venture into anything bigger than, smaller than a remnant of 30%. Maybe a remnant of 20% may be for experts rather than for general pediatric surgeons wanting to do. I generally would say, as a pediatric surgeon, I would suggest that you do wedge resections and probably do a very formal left lateral segmentectomy, or at the most a right hepatectomy. In fact, a left hepatectomy is much more difficult than a right hepatectomy. A right hepatectomy is more straightforward to do than a formal full left hepatectomy. So I would confine to really proper anatomical, very clear-cut resections rather than complicated resections in liver surgery. 20% is what we talked about. And now the CT scan should be able to give you volumes. There are programs available, and every good CT scan center should be able to tell you how much remnant is going to be there. So these are all not special investigations anymore. These are routine investigations that is available in good CT scans. And finally, this is a problem in adults, not in children, but in children also. Children with metabolic liver disease, obese children may have a fatty liver. It's not an uncommon problem in older children as well. So it's important to understand that the child does not have a fatty liver. If a child has a 30% fat and you are going to leave behind 30% remnant, so 1/3 of that liver is fat, and therefore you land up remaining with a 20% remnant. So you need to understand that you diagnose fatty liver. Sometimes post chemotherapy also the livers can become fatty. And again, this is available on the CT scan imaging. What they do is what is called liver attenuation index, where they compare the attenuation of the liver to the spleen, and the liver should be denser than the spleen, and therefore the liver attenuation index should be more than +5. If it is less than +5, it's a fatty liver, and if it is going in the minus, it's an extremely fatty liver. You have to be very cautious. And sorry, this is contrast CT post chemotherapy. I mean, this is, I think, misplaced. I was going to say in hepatoblastoma, you need to give chemotherapy and then only take them up for surgery, because chemotherapy will reduce what is meant to be a proper extended left hepatectomy into almost like an extended left lateral segmentectomy. So we'll talk about hepatoblastoma in a minute, and I'll conclude with that. This is the LAI. This is a very steatotic liver. The LAI are -21. This is a very healthy liver, which is denser than, and it needs to be done on a plain CT. You can't do it on a contrast CT. And this is very interesting phenomena. I always ask people when I'm looking at a plain CT, if you look at this liver, the vascular markings are more prominent here. The vascular markings in the left-sided liver are hypodense. The liver is denser than the vessel. Here, the vessels are denser than the liver. So the blood is actually denser than the liver. That shows how fatty this liver is. So this is a remarkable thing that you see in extremely fatty livers. And it's very important to understand and not venture into operating on fatty livers, because you will get into trouble. Fatty livers don't regenerate well, and post-operatively there is a risk of liver failure. And you cannot do that in a contrast phase, because in the contrast phase the liver becomes very bright from the contrast. So the LAI needs to be calculated in a non-contrast liver. So remember that. Hepatoblastoma, just a few words, because the examples I'm going to talk about is hepatoblastoma. And resection is really the gold standard for hepatoblastoma following chemotherapy. We came with recommendations for liver transplantation for hepatoblastoma. This is published in March in Transplantation. I've been involved in this consensus meeting organized by International Liver Transplant Society, where they tell you about which one not to resect and which one to send for liver transplantation. You've all heard about the pretext staging for hepatoblastoma, where pretext 1 is, pretext stands for pre-treatment extent of disease. Pretext stands for, pretext 1 is only 1 sector. So it's 1 sector, 2 sector, 3 sector, and 4 sector involvement. Obviously, 4 sector involvement is for transplantation, but 3 sector, 1 to 3 sector involvement, you can do liver resection, unless it's a centrally located pretext 2 tumor or pretext 3 tumor. You can, most of them can be resected, actually. Very few require to be referred for transplantation. As you know, hepatoblastomas can be very large, really, and your treatment can make a pretext 3 into a pretext 1, or pretext 3 into a pretext 2, and occasionally a single pretext 4 can also become pretext 3. So do not attempt liver resection without really offering them transplantation, and you will see that here, almost except for 20% of patients where they were pretext 4, hepatoblastoma presents as pretext 1 to pretext 3. 2 and 3 are probably the most common, and therefore majority of the hepatoblastomas would be resectable rather than offer them for liver transplantation. Now I'm just going to give 2 cases, and then we'll talk about, just show some videos, and then I'll conclude with that. 18-month-old child, just as an example, alpha-fetoprotein, higher the alpha-fetoprotein, the better it is. Good response to chemotherapy would be a rapid fall in alpha-fetoprotein to less than 1,000, but very, very high alpha-fetoprotein over 100,000 also indicates poor prognosis. So alpha-fetoproteins of 60,000 to 100,000 is not a bad, and also younger children have a better prognosis than older children. And here you see a very large tumor, which is centrally located. This, you would, if you see this tumor, you would offer it for transplantation, but there is also a single lung nodule. So the lung nodule disappeared post-chemotherapy. And what was surprising was the response was so good to chemotherapy. What looked like a very centrally, diffusely infiltrative tumor, you can see this diffusely infiltrative, centrally located tumor, becomes so peripheral and almost like becomes easy to wedge out kind of a tumor it becomes. And the chest CT shows complete disappearance of the lung lesion. Even patients with lung, you have to remember with hepatoblastoma, even with patients with lung lesions have more than 75% 5-year survival when they respond well to chemotherapy. The alpha-fetoprotein dropped from 60,000 to 83,000. And at operation, all you could see was a very, very small tumor that could easily be resected. The video of not this one, I'm going to show you another case, which is a very large tumor. And here is where your problem, this was a mixed tumor really. This was not a hepatoblastoma. It did not respond. The alpha-fetoprotein was not high. This was a 7-year-old child. Older children also have more like a mixed tumor rather than a pure hepatoblastoma. The problem here you need to remember is that the portohepatis will be stretched. The middle hepatic vein would run on the surface of the tumor and would be involved, and the left hepatic vein confluence with the middle hepatic vein would be interfered with, and therefore one needs to be extremely careful for this. With this, we'll just watch the video of this very large tumor being resected. So this is kind of a mixed tumor, arterial phase. The venous phase, you can see how they, I'm sorry, vein venous phase. Sorry. I don't know. I think we start again. Not a bad idea to look at the images once again. You can all hear me, huh? All gone silent. I think it's better in between to just speak. I hope I've not been speaking for the half an hour to somody that nobody's been listening.
We can hear you very clearly, sir.
Yeah, you can see the left vein there, how the left vein is very, very much involved. Very large tumor, requires an extended right hepatectomy. The liver looks congested because the venous outflow is also compressed. Cholecystectomy first. The right hepatic artery is already ligated. The right portal vein is looped. As I told you, the anatomy in children is very, very clear. I've divided the inflow completely now. Let me just stop and ask you, say something to you. Now, we have divided the inflow of this liver, and you can mobilize the right lobe. And in the older time, when I train, there will be some people who will mobilize the entire right lobe and then go and divide the right hepatic vein and then start the transection. And we used to have a lot of bleeding. I don't know if you thought about it. One might think that occluding the inflow and then occluding the outflow as well will reduce the cut surface bleeding because there is no more blood supply to the entire right lobe. That would be wrong, actually. By completing this step of the operation, I have not actually completely occluded the inflow to the liver. If I now go and ligate the outflow, the liver will get congested because the right lobe will still receive blood supply through the bile duct. As soon as you divide the right hepatic artery, the collaterals through the bile duct will open up pretty rapidly. If you divide a hepatic artery and then you do a CT scan after 2 months, you won't even know that you've divided the right hepatic artery. The collaterals through the bile duct will open up so rapidly. And therefore, it's not advisable to actually ligate the outflow before doing the transection. It is better to keep the outflow open. Now the inflow is significantly reduced. I have to say 90% the inflow is reduced, but it's not stopped 100%. But if you occlude the outflow now, even that 10% of inflow to the liver has nowhere else to go. It'll only bleed through the cut surface. So my advice for you is to occlude the outflow, but never occlude the inflow, but never occlude the outflow. when you're doing liver resections, because you need to keep the outflow open. Now the inflow is occluded. The liver is really ischemic. We're mobilizing the right lobe. So these are the caudate veins, and this is the the ligament, and you can see the cava is completely stretched by the tumor. That's why the liver looked very congested in the beginning. This is a short hepatic vein, inferior vein, which is divided. Now the right hepatic duct is divided. Once the right hepatic duct is divided, there is no more blood flow to the right lobe. After this, you can actually divide the outflow. It's not a problem. Now the right lobe is completely devascularized. So the right lobe is only devascularized after dividing the right hepatic duct, not before that. So we're just keeping a Pringle there. Now you can see that the transection plane is actually not on the ischemic side. The transection plane is between segment, left lateral segment and segment 4. So there is still vascularity to segment 4. Now we are dividing, as we are transecting, we are dividing the vascularity to segment 4. You can see the tumor bulging. There is some breach in the capsule actually, but sometimes this is not possible. Now we are dividing the right hepatic vein. I've tied one end so that we can rotate the liver fully. Closing the right hepatic vein. Some people use stapler for this. I think it's okay to use stapler if you've got the money to do that. I'm still an old-time surgeon that way. I do all my rule loops with hand and bowel anastomosis as hand switches. I don't use staplers still. Now we are getting into laparoscopic, and you've got a robot now, XI, so I've got to learn to do all these modern things now. Now, the risk here is, let me just pause here. This is where I wanted to talk to you about. The middle hepatic vein is stretched over the tumor, and the middle hepatic vein is inserting with the left hepatic vein and forming a common orifice. And the tumor is actually, you can see, I've opened, I've done a total vascular exclusion. I don't know if you've seen that. Sorry, I forgot to mention that. We've done in order to take this liver out, I had to do a total vascular exclusion. You can see the clamp is on the top across. And you see the middle hepatic vein. I'm cutting open the middle hepatic vein. There is no inflow to this liver at all. And you can see it's bulging into the middle hepatic vein. The tumor is not infiltrating the intima. It's bulging into the middle hepatic vein. So I'm cutting the junction between the middle hepatic vein and the left hepatic vein. And the tumor will come out. So the left hepatic vein orifice into the cava is higher up. You don't see that. But the middle vein into the left vein holes, you see there. So it's a total vascular exclusion. The tumor is taken out. And I'm closing. You're seeing the inside of the left hepatic vein now. So if you're leaving behind now 20% of liver remnant, and if you get the outflow wrong, you will surely get a post-hepatectomy liver failure. This is where you have to be very careful, understand the anatomy. Now I've done this. How do I know that I will not get a narrowing of the outflow? I have to do a Doppler to see. If I see a Doppler, or the other way indirectly to know that the outflow is not normal is to measure the portal flow. Because if you've got an outflow which is narrow, the portal pressure would be very high because the liver would be very congested. So those two are the ways. And if I find that the pressure is high or the outflow is not triphasic, then I have to put a venous patch on that hole. Then that will sort it out. So now we are opening the inflow and the outflow, and the liver looks perfect. I mean, you can see initially it looks patchy, but it will perfuse very well. I'm flushing the bile duct, the cystic duct, to see if there is any cut surface bile. And you can see that the transection plane is far from the IVC to the left. And this was actually a HCC. And the Doppler shows that the venous flow is triphasic. And surprisingly, the portal flow is only 5 or 6. And this is what I mean. Even though you think you've only left behind 20% of liver, the right lobe is mostly occupied by tumor. So most of the function is from the left lateral segment, actually. So you will not expect, and here we fix the left lateral segment because it's very important to fix the liver here because it can flip onto the right side. When the child is turned, it can flip onto the right side. Then you get an outflow obstruction. So you get like a torsion. So when you've got such a mobile left lateral segment, it needs to be fixed onto the left side so it doesn't fall. On the right side, obviously, all the bowel and the colon will go and sit on the right side. There is too much space on the right side here after the resection because the liver itself is very large. So that is what it is. And there is another example of a very, very large tumor. I was saying, if you don't actually anatomically visualize what we are saying, this is a child which had a very similar operation in Sri Lanka, but the left hepatic vein orifice was not properly dealt with, and the child came with a recurrence. So this is the child, and there was a recurrence there, which was protruding into the orifice of the left and middle vein. Very similar anatomy, dealt with differently, and we had to go and remove this this tumor. And I mean, liver surgery is all about vascular surgery. So if you're comfortable suturing blood vessels, you can do liver surgery very well. And this child has had a recurrence right at the top because they didn't know how to deal with the top of the junction of the middle and left vein. So they left some liver tissue behind and they left some tumor behind. So I'm going and removing the liver tissue with the tumor that they left behind. Again, I had to do a total vascular exclusion. As you see, the hepatic vein was blocked. The inflow, there is the top suprahepatic vena cava going into the right atrium. And then I open it up and I can excise the whole thing. There's no more inflow, so it'll bleed a little bit and then stop. This is just blood within the liver. You see there? So you leave behind a little bit of liver tissue, worried that you will get into the left vein. The recurrence is actually protruding into the IVC. Now this amount of IVC taken out and the orifice of the left hepatic vein is so large, I can't really close this safely. I'll get an outflow obstruction. You see on the left-hand side is the orifice of the left vein. So I took a patch of PTFE and then cut to the shape that I removed, and we closed this patch. This was a hepatoblastoma, a recurrent hepatoblastoma. I think this child developed another recurrence on the diaphragm, which probably was a spillage during this operation and had another operation to remove it about a year later. So where you can't safely close a vein, you have to really use a patch to do that. And there, the liver is fully regenerated. The inflow is being removed. Again, this was done under total vascular exclusion. So I think liver surgery yields all sorts of possibilities, and it's all about understanding anatomy. And simple liver resection is something I'm pretty sure all of you can do very comfortably. And that's the final result, and that's a specimen. And really, that's the child who had the last operation post-operatively. Lost all the hair due to chemotherapy. I think that's my last slide. And thank you very much. Am I back now?
Yes, Professor Rela, you're back. 1 minute. Let me try and see if I can get Yeah. Thank you very much. I think that was a very, very illustrative and very nice talk from basic anatomy, as well as what is standard and what is sort of extended stroke extreme resections that is possible. I think I will hand over to Ravi, because he would probably read out the questions that are directed to you, and if anything is left, I might add some at the end.
Yeah. So there are few questions from the audience. First of all, sir, there is a huge round of applause which we cannot hear online, but everybody is clapping on YouTube for the extensive presentation, and everybody is appreciating that. So thank you for that. I'll start with the questions. We have a few from Nitin. Nitin is one of our colleagues and early adopters of hepatobiliary surgery. He's asking that what is the role of intraoperative ultrasound in the era of modern imaging? We saw you checking the blood flow after the resection. Do you do it intraoperatively before you start the resection? And
no, I don't do because I think a CT scan gives a much better understanding prior to the surgery. If you do a good quality CT scan, it's very useful. In liver surgery, I think we would only use intraoperative ultrasound mainly for metastatic liver disease. In colorectal liver disease, where there are 5 lesions on the CT scan, or there are smaller lesions that is seen on MRI, not seen on CT. When there are multiple lesions that you're dealing with, intraoperative ultrasound is very good for defining these multiple lesions. I think on the pediatric surgical setting, mostly these are large tumors and single tumors. I've never had to use an intraoperative ultrasound to define the anatomy during the operation. I think a CT or an MRI is far better in telling you preoperatively what's the anatomy is going to be. It's only to detect unseen lesions that you need intraoperative ultrasound. It could be so for HCCs when they're multifocal. They may be useful for HCC.
thank you. Nitin is again asking, you didn't spoke much about the central hepatectomies. So he was interested in knowing that what is your experience with these central segments or the mesohepatectomies?
Yeah, I mean, we have done many central hepatectomies, probably not so many in adults. I thought I'm talking to a general audience. I've already shown actually much more complicated liver resection than I should be talking to the general audience. I think in simple terms, I think central hepatectomies require much longer operation because you've got 2 cut surfaces. I do believe that it should be really done anatomically. A central hepatectomy is when you want to remove the anterior sector of the right lobe and the medial sector of the left lobe, which is segment 4, 5, and 8 resection would be your central hepatectomies. And you could do that for centrally located tumors. I see it as 2 operations combined together. You should not think of it as a complicated central hepatectomy. You start off thinking, I'm going to do extended left or a extended right, extended left hepatectomy. So you start off with that plane between the anterior and posterior sector in front of the right hepatic vein. Complete that transection, and then you go and do like a left lateral segmentectomy, the plane between the left lateral segment and segment 4, and complete the transection. And once you've completed these 2 transactions, you deal with the middle hepatic vein will be hanging in the middle. And you can deal with the middle, the vessels, the inflow right at the beginning or right at the end. I want people to see it as 2 resections combined together to do in one day. It's a right-sided plane, a left-sided plane. Both are well-known anatomical plane. Do the transections that way and then complete the operation. So you've got the central tumor stuck to the cava in the back, with the middle hepatic vein as the superior pedicle, and the inflow as. But the inflows can be taken separately. It's not actually difficult. I mean, people see it as a big operation because it requires 2 cut surfaces, 2 transections.
There is a few questions about biliary atresia related liver transplants. So people are asking your comments on what are your specific indications for a primary liver transplant in biliary atresia patients, and then the indications after a Kasai procedure in biliary atresia patients.
I have to say, there is no role for not doing Kasai if the child is under 3 months of age and going for primary liver transplant. Or you might say if you're very strict, under 2 months of age. I think you should never say when a child comes with biliary atresia early to you, and you say, I don't believe in Kasai operation, go for a primary liver transplant. I think that is not acceptable. So there is no such thing as a planned primary liver transplantation for biliary atresia. But unfortunately, in our country, the diagnosis of biliary atresia is missed, and almost 30 to 40% of children come without having had Kasai, with liver failure, and have a primary liver transplant. But that's not a planned, it's a disaster really, rather than a planned primary. I don't think operating on somebody who has had a Kasai operation is so difficult that one should be thinking about primary. I think a primary liver transplant obviously is easier to do than after post-Kasai, where there are a lot of adhesions. But that easier dissection is more than compensated by these children coming much more wasted and much younger. So you will find that the patients who come for transplant without having had a Kasai are always much, much smaller. They may be less than 5 kilograms, less than 6 kilograms. And therefore the technical aspects of liver transplants, like you may have to resort to monosegments and things like that. So it more than compensates really. Whereas when you do a Kasai, they come after 8 months, 10 months, 1 year, and they're much larger children and easily accommodate a left lateral segment comfortably. And therefore that aspect of the operation becomes much, much simpler. So I will not advise people to tell their patients not to have Kasai. I think if there is an indication for Kasai, they should have the Kasai and come for a transplant when the Kasai doesn't work or when they have liver failure. The indication for liver transplantation should be a liver failure or recurrent cholangitis or failure to thrive, all of those, rather than not coming as a primary operation.
Sanjay Rao, sir, you have something to add on this?
No, I think I agree 100% with what Professor Rela says. It is very important. I think there is a sense of despondency about the Kasai operation. I think partly because most of the time when we get hold of these patients, they are 3 months, 4 months, 5 months. And I think that sort of reflects on our general decision making and general despondency with the Kasai procedure. But I think the Kasai procedure, as Professor Rela mentioned, is something that we should offer whenever it is possible in a child, and that is anybody who is at a suitable age for Kasai must have one. At the time of Kasai, if you end up with a liver, when you open the patient for Kasai, say somebody who's 2.5, 3 months old, you open for Kasai and you find the liver cirrhotic, you might back out. But then it's not something that you should say, no, we can't do Kasai, doesn't work, you please go for transplant, when they're otherwise suitable for Kasai operation.
Yeah,
that's perfect.
Sanjay sir, most of the major questions are over. I don't have any more questions. Would you like to add us on any particular matter?
Again, some of the questions that I had written here, I think Professor Rela has already answered. As I said, as you said, liver resections are uncommon operations for us as pediatric surgeons. Even in big centers, we probably see a handful of hepatoblastomas coming every year, and it is even less when you are out in relatively smaller places. So I think the message that needs to get through is what is it that we can do safely, when we are not a sort of labeled hepatobiliary sort of center, if you want to use that kind of a term. What can be done safely, and what is something that we need to refer? So what are the red flags that you would say, if I have these things, I should not take this patient on and I should refer? I think you alluded to, but I think it would bear repeating, Professor Rela.
Yeah, I think it's right, actually, what you have said. I wanted to start with a positive note and say, actually, pediatric liver resections are much more straightforward than the adult liver resections. If you're a careful surgeon, if you're a good surgeon, you're able to do. But your problem is that the numbers are the problem. So no one surgeon, if all pediatric surgeons wanted to do liver resection, you'll all be doing 1 or 2 a year. Never going to be more than that. But even as experienced people, we do around maybe 10 or 15 a year at the most. So the numbers are going to be a huge problem if everybody wants to do. And if all of you do, we'll also be doing less anyway. So the it's very clear. The difficult cases, I don't think you should be touching. Where the remnant is low, you shouldn't be touching. Where it's a tri-segmentectomy, you shouldn't be touching. But if you're a good surgeon, if it's a very straightforward resection, I don't think I will not say you should not do it. But you have to be prepared to do this operation safely, because you need to remember in your mind that this operation, particularly the ones that you want to do, almost have to have a zero mortality, because that is the norm in the straightforward hepatectomies in children should carry almost a zero mortality. I'm not saying absolute zero mortality, but definitely less than 1% should be the mortality of these. And if you feel that you're able to offer that safely to the children, I think it is good to do. And there are many equipment, specialized equipment that is required to safely do it, like accuse, which is much better than really finger fracture. In terms of technicalities also, you may be handicapped in order to do a very safe operation. I'm not saying you should never do. There are very many of these liver resections that can be done safely. I would beg you to keep the mortality extremely low. And if you believe that you are not able to offer a resection with that level of low mortality, then you should not do it.
Right. The other question that often comes up when you do any kind of hepatobiliary surgery is about bile leaks, and you alluded to it. Waiting for too long makes these children very sick, and then rescuing them later on becomes extremely difficult. So what would be your advice? Say somebody has done a biliary trace, a liver resection or a choledochal cyst or something like that, and they have a bile leak that is coming in the drain day 3, day 4, day 2. What would be your approach? Is it based on volumes? It is based on, how do you decide when to go in? And
yeah, you've said already, it depends on the volume actually. If it's a very small volume, and in the next few days it appears to be clearing and it's slowly becoming serous, I would tend to wait. But if the volume is large, you have to re-explore, because that means you've damaged a larger duct. In a left lateral segment, it may be a segment 4 duct. The unfortunate thing about these things that people make a mistake is they think that it is coming, if a leak is coming from a main duct system, you can demonstrate. People go in and put a stent in, or they say, let me put a stent at the lower end of the bile duct to release the pressure. But a disconnected duct will not be seen on imaging. Your ERCP will not show a disconnected duct. What I showed you about the anatomy, the right posterior duct entering into the left duct, if you disconnect it and if it's leaking on the surface, a ERCP will not sort it out. So the general idea for people is, oh, let me do an ERCP, put a stent across, it'll stop. It will not stop. Segment 4 leak will not stop. That is why it's very important to understand what surgery you've done and what is the likelihood of this bile leak. And if you understand that this bile leak, if the bile leak is from the main system, if it's a left duct stump leaking, if you believe it's a left duct stump leaking or a right duct stump leaking, a ERCP will sort it out. But if it is not the main duct system leaking, it will never stop. It really is understanding anatomy. And then if you feel that you can't manage it, it's probably better that you offer it to somebody who can manage it. So major bile leaks are a major problem. Don't sit on major bile leak for many days. And if it doesn't resolve in a week, you should definitely not sit on it. But small volume leaks, which appear to be really slowly getting serious with time, is not a problem.
So I think that's about the questions that I had. The other thing was, you showed some of these extreme resections which required patching and reconstruction of a remnant left vein, the last 2 patients that you highlighted. So what would be your threshold to say that this hepatoblastoma is not resectable and needs to go for transplant? Is it just pretext 4 once, or what's your decision making? Because theoretically, you are able to reconstruct most of these blood vessels.
Yeah, I will see. There is something that we have learned from that was a HCC that I resected. I wasn't a pure hepatoblastoma. If that was a pure hepatoblastoma, I would have gone for liver transplantation. What we have learned this we have learned over the years, don't do heroic resections for hepatoblastoma, because transplantation for hepatoblastoma, the results are so good. If you do resection for hepatoblastoma, and if you get a resection, if you get a recurrence, and then do a transplant later, the long-term survival is very poor. So it's always better to go for primary liver transplantation instead of doing the surgery that I showed. Recurrence always carries poor results when you do transplantation as a second stage operation. Whereas if it's a pretext 4, if you do a transplant, the outcome is extremely good. But for other tumors, if you can avoid a transplantation, resection is far better. Whenever I can avoid transplantation, if I can do a safe resection, I would always go for resection rather than transplantation. This patient, which was a mixed tumor, which was more a HCC rather than hepatoblastoma, the alpha-fetoprotein was actually normal. I would always go for resection as much as possible. Even if I have to take the liver out and resect and then put the liver back in, I would go for a resection. So in general principle, I would say I would avoid transplant as much as possible and go for resection in any tumor where resection is a possibility, however hard you try, except for hepatoblastoma, where if you get a recurrence after resection, your results are poor after transplantation, and therefore I would offer them for transplantation rather than do heroic resections.
Yeah, I think that was very, very clear. Thank you very much. I mean, that was the list of questions that I had that I thought would be of interest. So I'll hand back to Ravi and Ravi, can you hear me?
He's muted. He's talking, but he's muted.
Yeah, sir.
Yeah.
One question about the methods of cutting through the liver. We saw you using the CUSA. So is that your favorite method to do
Yeah,
it?
it is.
Or
It is. It has always been my favorite method, and that's what I use.
what is the next best option? Because not everybody would have CUSA available at their institute. So what would you advise to them?
People use harmonic. The only thing about harmonic now, I think people are using harmonic more and more now because with the laparoscopic surgery as well, people have started using harmonic. I would say that's okay, but it's more difficult to define anatomy when you're using a harmonic.
Okay.
I think for extensive surgery like what I did, it may not be safe because you won't be able to see the anatomy. But I think it's quite acceptable. And even if you're happy to take your time, even a Kelly fracture would be okay. But that'll take its time, and you have to use it with the bipolar diathermy or monopolar diathermy simultaneously. If you're experienced enough, any technique would be good enough. I mean, if I've had instances, not now. I mean, we have 3 CUSA machines in our hospital. When we had 1 CUSA machine, and in the middle of the surgery, the CUSA machine, if you have only 1 machine and it breaks down and you can't get it back to work, you have to use your finger fracture. I mean, not finger fracture. I wouldn't use a Kelly or a mosquito fracture technique is good enough to complete the operation.
Okay. Kirti, would you like to ask anything? Then we'll conclude after that.
Yeah, so there was a question in the audience, like, what is your opinion about laparoscopic liver resection, maybe robotic liver resection some people are doing nowadays?
Yes, I think that is the future. That is here to stay. It's not going to go away. For all straightforward operations, obviously, not those involving vascular resections and things like that, I would say laparoscopic or robotic is going to be the future. We have got a robot now. I have to say that. We are getting into it.
Okay. So, Sanjay Rao sir, I think.
Just one other question. Can you just allude to vascular tumors, hemangiomas, hemangioendotheliumas of the liver? And I think that sometimes they are challenges, and there is a little bit of ambiguity about how you manage them. Again, for the same reason that numbers are few. But I'm sure that as a person, you might have seen a large number of these.
Yeah, I'd see one other thing. I would give you an example. Large infantile hemangioendotheliomas. Many people, we used to do resections on them. We used to do transplants on them. They present with heart failure sometimes. I don't know how many of you have seen them. I always start off pediatric liver resection in the olden days with that. I've had patients sent to me for resection. Do not resect a large infantile hemangioendotheliomas. They respond. They involute actually very rapidly. Within 6 months, they involute. People have been shocked to see that I've said it doesn't require surgery, and they disappear, and we have managed them really medically, and they go away. So the ones that require resection are actually the epithelioid hemangioendotheliomas. They are not actually, they are older children or young adults, and they are actually multifocal. In fact, they require liver transplantation. I don't think I've seen many epithelioid hemangioendotheliomas which are which are single, really, single and large, which require resection. So think twice before offering surgery for infantile hemangioendotheliomas.
Okay.
Yeah, that's it, Ravi. I think, yeah. Thank you. Thanks, Professor Rela.
Okay, sir. With that, we will conclude this. I would thank you from the bottom of my heart and on behalf of the entire fraternity of IAPS for coming here, giving this such elaborate and lucid talk. Everybody is really appreciating it, sir. And we have had a steady audience of almost touching 200 people who watched you live on YouTube. And
Thank
probably
you.
many more would be watching this recorded version. It will be there. Kirti will send you the link. And it has been great having you here on this platform. And Sanjay Rao sir, once again, thank you for being here and moderating this session with Dr. Rela. And thanks to Kirti also for bringing Dr. Rela. Dr. Rela, we would hope to listen you again, maybe during our IAPS and more on other pediatric topics. And it would be really wonderful to, have a few more talks on IAPS. We hope to hear more from you, sir.
Thank you. Thank you. I'm sure we'll meet again. Thank you very much.
So with this, we'll finish this session, sir. We can leave this meeting now. I'm stopping the live stream. Thank you once again. Thank you, everyone.
Thanks, everyone.
Thank you. Thanks, Professor Rela. Thanks, everyone. Thank you.